Hi, I'm Dr. Peterson with Regions EMS. The new 2014 guidelines include many changes. There are some guidelines that did not change much at all, so let's briefly review some of the general medical guidelines for adult and pediatric patients. Guideline 21, Allergic Reactions and Anaphylaxis, distinguishes reactions into mild, moderate, and severe categories. The key decision point is whether there is hypotension, oropharyngeal swelling, or significant respiratory distress. Any of these symptoms would be considered severe and would warrant epinephrine administration on standing order. Epinephrine should be given intramuscularly into the lateral thigh, preferably with an autoinjector if available. There is a risk of a cardiac event in patients with heart disease or who are over the age of 50, so if the symptoms are questionable, medical control should be contacted prior to administration. Epinephrine should never be given IV unless symptoms are severe, refractory to IM injections, and after medical control consultation. Pediatric management is very similar with the exception of the weight-based medication dosing. The diabetic guidelines for both adults and pediatrics have not changed much. Hypoglycemia is still managed on scene and appropriately dispositioned if improvement is noted as described on the guideline. The pediatric diabetic guideline, number 49, is very similar except for the dextrose concentrations, which should be used for various ages, typically under the age of 2. These can be mixed by diluting the dextrose with normal saline, as noted on the guideline. An important point is that anyone who is on oral diabetic medications, with the exception of metformin, are at a high risk for recurrent hypoglycemia and should be transported for further evaluation. Guideline 26 is a new guideline to address hypertensive adults. Many times, EMS is called for evaluation of asymptomatic hypertension. High blood pressure is a health risk over many years and rarely presents an acute emergency. In fact, lowering a high blood pressure is actually risky in the acute setting, as the brain can become dependent on the high pressure for adequate perfusion over time. This guideline is intended to identify those patients who do not require EMS transport for an isolated complaint of hypertension. Consider pain, anxiety, and drug use as contributing factors and treat accordingly. An EKG should be obtained to look for evidence of ischemia, and if the systolic pressure is less than 220 and the diastolic pressure is less than 120 without symptoms, patients would probably be better evaluated by a primary care physician for long-term management of blood pressure issues. Any symptoms as described in the guideline should be considered for transport, and of course the patient should be in agreement with the plan. At the other end of the spectrum is hypotension and shock. Guidelines 27 and 50, adult and pediatric hypotension, are very similar. If trauma or bleeding is suspected, control the source and treat appropriately. Otherwise, the priority would be fluid resuscitation first, up to 2 liters for an adult, followed by pressor agents such as dopamine or epinephrine. Now, you should never initiate a pressor until the patient has been adequately hydrated, as you really can't make the pump work any harder until there is actually fluid in the tank. The exception to this would be cardiogenic shock, which should be suspected if significant leg swelling, pulmonary edema, cardiac symptoms, or jugular venous distension is noted. In this case, IV fluids should be avoided and a pressor started sooner. Unless your patient is a resuscitated cardiac arrest, you should contact medical control prior to starting any pressors. Guideline 29 deals with adult respiratory distress. We have combined all of the respiratory guidelines into one unified resource. The key medical decision is to differentiate upper and lower airway issues from pulmonary edema. Upper airway issues in adults are not very common and should be very concerning. Epiglottitis, tumor, or a foreign body would be the main concerns. Asthma is less common over the age of 40 as COPD becomes more prominent, especially with a smoking history. NEBs are always the first-line treatment, and review the backside of the guideline for more information on the management of asthma versus COPD. Pediatric respiratory distress, or Guideline 52, is very similar, and treatments should be targeted based on upper or lower airway concerns. It is important to keep the environment as calm and familiar as possible to avoid further agitation of the child. Now let's review the seizure guidelines, numbers 30 and 53. Most seizures are self-limited and stop after a few minutes without treatment. If your patient has a known seizure disorder, no trauma was involved, and they return to their baseline mental status while in your presence, they may safely refuse transport if there is an appropriate disposition. Seizures should generally only be treated if they are prolonged or unusual for the patient. For EMS providers, this means you should only treat a seizure if you personally witness any seizure activity. If the patient is seizing on your arrival or at any point in your presence, consider immediate midazolam administration. The intramuscular route would be preferred if an IV has not yet been established. The dose can be repeated according to the guideline, and you should consider rapid transport and medical control consultation for prolonged or refractory seizure activity. The key difference in pediatric patients is the presence of a fever with the seizure. Uncomplicated febrile seizures, defined as a single brief episode without trauma and a return to baseline mentation, can often be signed out to a responsible parent or caregiver for observation or private transport. Supportive treatment with Tylenol and ibuprofen should be encouraged. If there are any unusual circumstances, symptoms, or concern for meningitis, the patient should be transported by EMS. Medical control is always available for consultation in these situations, and as usual, any child under the age of 2 requires physician clearance prior to a non-transport signature. The final medical guideline we will review is the Adult Syncope Guideline, number 31. Now, there are many causes for syncope, most of which are benign. However, it can also be the initial symptom of a more serious underlying medical problem. This is especially true in the older population. Unless your patient is young, healthy, and has a reasonable explanation for what triggered the episode, you should strongly encourage transport for cardiac evaluation. An EKG should be considered in all syncope patients to evaluate for evidence of an arrhythmia, and this is an important part of the evaluation. The backside of Guideline 31 provides additional information on the evaluation of a patient with syncope and should be reviewed.